curiosity why.
Madbricks webcast,
Where the human spirit flies. Madbricks webcast, where the human spirit flies.
Welcome to the Medbits webcast. This is Ramana Annamaraju, the host. My co-host is flying on the hurricane somewhere. I don't even know. So I hope she will return back to her roots with the hurricane, along with the hurricane. wish you all the best to my co-host Susan Davis. She's a doctor of nursing practice. So I wish her all the best. During the time I've been in California and live from Silicon Valley. Now one of my favorite guests is my good friend, and he's been coming a long time. He's a great supporter of Medbits Webcast. I'm going to introduce him in a second, but I want to talk with you about a little bit about what we're going to talk about. In physics, there is something that I'll talk with him about that a little bit. Physics is there are four principles: gravitational force, and electromagnetic force, strong force, nuclear force. Einstein spent the last 30 years in one. He thought that there is only, because they all came from one place, so there should be a root cause for all these forces. When I ask a cancer specialist, what is cancers are millions, they're different, hundreds of them. That answer doesn't go very well with me. So I'm going to put a tough question to my guest now. Let me introduce you my guest now. That is, ladies and gentlemen, it is my distinct honor to welcome one of the world's foremost authorities in radiology and head of the head and neck imaging, Dr. Suresh Mukherji. Dr. Mukherji has authored more than 500 scientific publications. Just like a napkin, she's throwing all the publications now. And 15 medical textbooks. 16 said that. Oh my God. Delivered over 600 invited lectures across 6 continents and earned an H-index of 77. I don't know what that is. I want to ask him. Reflecting decades of scientific influence. His pioneering work in advanced imaging, including MR spectroscopy, CT perfusion, and AI-assisted radiology, has transformed how physicians detect, characterize, and manage cancer. Beyond the extraordinary academic achievements, Dr. Mukherji is shaping the future of medicine. As a professor of radiology and radiation oncology, past president of the American Society of Head and Neck Radiology, president-elect of the Indian Radiology Society, and leading advocate for the safe clinical adoption of artificial intelligence. He continues to influence healthcare policy, medical education, and patient care worldwide. Tonight, he will share his vision for the future of cancer diagnosis, precision imaging, AI, and the innovation that save millions of lives. So, can AI truly outperform radiologists? That's a question I'm going to ask him. Welcome, Dr. Mukherji. Welcome to the podcast.
Hey, Ramana, how are you? It's good to hear your voice.
Your introduction is still short. I can write 200 pages. I don't know where I start, where I begin. Your introduction is a huge. You travel quite a bit, and then I wanted to ask you. Just give us your background a little bit. Everybody knows, but I mentioned background. You went to Harvard, right? Actually, give us a little bit about your background, and then we can talk about stuff.
Yeah, sure. Well, first of all, I want to congratulate you. I think MedBricks started during COVID, if I recall.
Yes, sir.
And I think I first saw something that you sent out on LinkedIn 5 or 7 years ago or something. And I think I remember when we first did one of the first couple, it was a bit of a challenge regarding all the production issues, but over the last 5 years or so, you've really streamlined the process, and I wanted to congratulate you. You're very kind to have me participate on multiple occasions over the last 5 to 7 years, and I'll always be supportive because I think what I always look for people are people that are passionate and that also are persistent and also have an ending a desire to create something new, and I've always appreciated about that of you. So, from my standpoint, looking from where I am, it's just been a continuing improvement and success for what you've created in MedBrooks. And even now, when I look to the lineup for August, it's really amazing what you've done. So, congratulations to you.
Thank
And
you, sir. It is coming from you is truly an honor. Yeah. Just give us a little bit of your background. You're no less than anybody else there. So give us your background a little bit for us.
Yeah, sure. I think especially as it pertains to this webinar, I went to undergrad at Duke University, and I actually worked on some of the small molecules that at that time back in I went to undergrad in 88 to 90, 79 to 83. So it's actually 4 decades ago, which is a little scary. Hopefully it look like I'm 4 decades of experience, but back in 79 to 83, I was working in the lab, actually working on small molecules for specific cancer treatment. So I know we're going to be touching on why does it take so long, or what are some of the hurdles new cancer therapeutics have to go through. And then after that, I went to medical school at Georgetown, was a radiology residency at the Brigham and Women's Hospital, which was part of Harvard Med School, still is, obviously. And then did a 2-year neuroradiology fellowship. And then I was an assistant and associate professor at University of North Carolina, and then a full professor at University of Michigan, was department chair for a while. And now I've pivoted a little bit in the sense that, I have more yesterdays than tomorrows. So now I spend 2 days of the week doing clinical work with a private group, but then the other 3 days I have 6 academic appointments. And the reason why I decided to do that through different institutions is it allows me the flexibility to do other things besides being, I don't want to say constrained, but, being part of one institution is great. But on the other hand, for me, it's wonderful experiencing different approaches to problems as opposed to a one-size-fits-all. It allows me to do a little bit more consulting on the side too, which includes consulting with healthcare purchasers and payers. So I have an MBA. So I know web podcasts in the past, we've talked about the healthcare purchaser and payers perspective on healthcare and how that differs oftentimes from us as being practicing physicians. And then I was also head of the Certificate of Need Commission and on the commission for the state of Michigan for about 10 years. So, when I look at things, I like to talk about healthcare as the 7 Ps, which are the patients, which are the center of our healthcare ecosystem. Then we have the physicians. Then we have healthcare purchasers. They play a very important role because when they purchase our services, they really feel that they're paying essentially our salaries. So they feel that they have an important role. Then we have our payers, which are a lot of the insurance companies. Then we have the politics, which I know you're involved in. Then the 7th P is actually pharma, with the pharmaceutical industry. So when we talk about new drug development, it's important to understand the essential role that pharma plays, because when we as physicians use these medications or patients are treated, the vast majority of these are from the pharmaceutical companies. So in order for us to move forward as a system, a healthcare system, and try to add as much value, which is improve quality, decrease cost, and improve access, it's important to understand the perspective of all of those individuals that contribute to the United States healthcare ecosystem.
You beautifully laid of 7 things. I loved it. Let us start with the first one, patient. Dr. Mukherjee, the problem with the patient, not with the patients, it is very frustrating understanding cancer. Why we put trillions of dollars in it, the tax dollars went down inside. Why the cancer is still a struggling problem. Still, we don't have solution. Extremely expensive. Extremely, it is a big burden on the families. It is not a. It is not a. It is a quite some. Why we can solve this? Is it money, or is it scientific limitations, or where do you think that we are really not advancing so much as expected?
Um, I think there's a lot of ways to kind of tackle that. I
From a
think that,
patient point of view, I'm talking about you. You
yeah, from a
expected a
patient
patient.
point of view, yeah, I think part of it is if you really take it from a patient's perspective, and I see this all the time because I'm a big college basketball fan,
Ah,
and Dick Vitale has been an iconic broadcaster for many years in college basketball. Someone that I've always
oh,
looked up
really? I
to.
didn't know
Yeah, I
that.
met him years ago, back and again in the 1990s. But he has quote unquote cancer, and
Who
he's
is that?
been
Who is
very
that? Who is that
Dick
gentleman?
Vitale, the basketball announcer.
Okay,
So, but
okay.
he's been very public. He's been very public about his fight. But the term is that they keep talking about cancer as a single entity, but it's not a single entity. It is obviously a very complex disorder. It affects different parts of the body, and as we're learning right now, it has different, molecular and genetic types. I will say one thing that I think from the layperson. I mean, my father died of cancer. My father-in-law died of cancer. So I think all of us have had, loved ones affected with quote unquote cancer or some form of it. But I think the point that I want to make is if we look at it over time, there have been remarkable advancements in the treatment of cancer. So if you think that we're going to eliminate or eradicate all forms of cancer, that's just not going to happen. But on the other hand, I think when we do look at cancer, we can't look at it from a day-to-day perspective, but we have to look at it over time. And so what I mean by that is the following. When I was 16 or 17, for some reason, I don't know why, I would go to my annual checkups with my doctor. So I would go to the doctor, he would look into my ears, he would look at my mouth, and that didn't bother me. But for some reason, every time that I would go, he would feel the base of my neck. Okay. And both my parents were physicians. So he would feel the base of the neck. And I know what he was looking for. He was looking for enlarged lymph nodes. And when you have enlarged lymph nodes back in the late 1960s, early 1970s, and you had large lymph nodes in an adolescent, that was an indication of Hodgkin's disease. And at that time, Hodgkin's disease was incurable. It was a death sentence. So I was always worried about that. If they felt something, oh my God, I'm going to die. My father was a pediatrician, and I still remember him making a comment about Wilms tumors, which was basically a childhood cancer that afflicted the kidneys. And again, back in the 1970s and 1980s, when children had this, again, he used the term death sentence. You always listen to your parents, but there's certain moments when you reflect back that are embedded in your memory. And one of those things was Wilms tumors was a death sentence for children. And, there are numerous instances which now a lot of these cancers that, such as Wilms tumors or Hodgkin's disease, were incurable. They're now curable. They're now treatable. So I think one of the points that I want to make is that when we look at the continuum of how we've been able to address various types of cancers, we have made a substantial amount of progress. Even when you look at the most common tumor, and that's breast cancer, now we have the triple therapy. We can now do specific molecular testing, and we can target our therapies. So my point is that we have made, I think, substantial progress, especially when I look back on my quote unquote experience of my lifetime. Because I guess I'm old enough to say, I mean, when I grew up, John Kennedy had just been shot. Dallas was known, the city Dallas was not known for the Dallas Cowboys, but they were known for where Kennedy was killed. So my point is that it's been about a 60-year journey for me. And at times I do kind of reflect back and to see how things were in the past and where we are now. And overall, I think we've made a lot of progress. Are we there yet? Absolutely not. Are there opportunities? 100%.
Yeah.
But on the other hand, I don't want to. I don't want to leave, this group or the audience saying that we haven't done enough. And we can talk about this about.
Yeah, there's the
You
next
know, I
step.
know when the I know when the publications that went out, why are there so many delays in cancer care and why is there a delay in getting treatments? So we can address all that.
Since you're
Overall,
talking,
I think we made some amazing advancements.
since we're talking about patient, just one more add. I want to add a little bit of addendum for that. Is that families around the patient, how do they convey the message? Is it terminal cancer or it is equitable? It is one of the things. Where is radiation oncologist as a cancer specialist? How do they convey that message to? What do you suggest to the patients? Hey, I am dying, or patient families are just very heartening news. So how do you disheartening news? Well, how do you put in that perspective of a healthcare point of view?
Yeah, I mean, I'm a radiologist, so I spend a lot of time doing CTs and MRs. But I think one of the things that is somewhat unique about me, and then maybe provides me a little bit more insights than the average radiologist, is that I do see patients once a week. So today is Wednesday, and every Wednesday afternoon, I'm actually at head and neck tumor clinic. So just now we were, going over patients with newly diagnosed head and neck cancers, which is kind of an unusual and a
Mhm.
unique experience that I've had over the last 7 to 8 years. So all of us are involved in tumor boards, which is multidisciplinary care. But for me to be able to actually go in the room, be there when they tell the patients that they do have a cancer, for me, that gives me a little bit of a greater insight than maybe the regular radiologist. I think one thing that I've learned over time is that once you tell a patient that they have cancer, they don't hear anything else. I mean, I think you want to, at that time, provide empathy. But when you ask, I know patients, what else was involved in that initial interaction, they don't remember anything.
Yeah.
It's like, oh my God, what do I do now? So the questions that are generated or the information that you may try to provide as soon as you tell the patients that they have cancer goes into the ether, goes into a black hole and they don't remember anything.
Okay.
I think from my standpoint, again, as a radiologist, because I don't initiate the chemotherapy, I don't resect the tumors, I don't deliver the radiation therapy. But one thing that's incredibly important for me when I see these patients is to ensure that we're going to do everything we can to help treat those patients. And I think the number one thing that you can do is that cancer is not treated by a single doctor. It's treated by a team. And I think the one reassurance, I think, first of all, the patients obviously want to know, is it curable? What are the treatment options? At some point, from their standpoint, we as physicians want to talk about the different treatment options, right? From a patient standpoint, the things that go through their mind are absolutely, can I get cured? What are the morbidities? What are the options? But from their standpoint, they have other issues they have to deal with. You don't know
Family,
the
children.
social consequences. A lot of these patients, part of success is choosing the right parents. And it's possible that these individuals are the breadwinners of their families, and they may not have the resources that others had. So all of a sudden, if they're disabled for a while, they may not have an income. They may lose their jobs. I was recently at a seminar where there were a lot of patient care advocates, and a lot of the patients that never told their employers that they had cancer. Why? Because if they told their employers, their concern was their employers would try to somehow eliminate their positions or could potentially fire them. Now, that's against the law. But on the other hand, these are things that people think about. So just realize that when you do deliver that information to a patient, we as physicians want to talk about treatments and cures and outcomes and so on and so forth. From their standpoint, they're worried if they're going to make it. But oftentimes that individual who's in their anywhere from their 30s to their 60s may be the primary breadwinner of their families. And they have other things that they have to think of too.
Dr. Mukherjee, you made an excellent point. The problem is that the moment you say the cancer, everything is in the ether or is gone lost in black hole. The thing is also there is no national strategy how to deal from there onwards. There must be a strategy should be given, given that process. Hey, once you said cancer, this is a strategy, a national strategy to be in place. Instead of spending billions of dollars on arms and fighting, I think we need to spend some money on that strategy itself. What is your opinion on that?
Yeah, I think the strategy in part has to be clear. Number one, I think when I look at a strategy, I think part of it is to ensure that every single patient has access to the latest treatment that are available for their specific type of cancer. Now, a lot of the cancers are curable, some are incurable. So for instance, with me being a head and neck radiologist, I know that a patient comes in that has a cancer of their throat and we test and it's HPV positive, then there's a pretty clear-cut pathway to help treat those patients. And those resources are available. So for instance, I review for the NIH through a separate entity. And when I review a grant, it's necessarily not for the scientific merit, but to ensure that, is this going to result in healthcare disparities? Are new medications going to be available to everyone?
So my question to you is there any national strategy after declaring cancer at the patient's steps 1, step 2, step 3? Is there any national policy is there, or there is just the individual doctor's decisions, all of them are depending on the doctor?
Yeah, there are guidelines on how cancers should be treated. Those are the NCCN guidelines, the National Comprehensive Cancer Center guidelines. So in general, patients can look at a document and determine at least what the baseline or the best practices are to treat their cancer. I think that's about as close to a strategy that we have. And that's from a treatment standpoint. From a payment standpoint, obviously if you're over 65 and you're on Medicare, you can get treated based on, your ability to qualify for Medicare. So I think there are payment policies in place. If you're below that age and you are sort of reliant on your individual healthcare payers. But as far as an overall strategy, I don't think that's really in place right now. And I think also, Ramani, strategies are also in a way a double-edged sword. I think the baseline is that if you have a cancer and everyone gets access to being treated with the cancer in a certain way. So for instance, that's somewhat similar to what they do in Sweden and to what they do in Canada, where it is a healthcare system that provides access to all citizens of the country. And if you do have a cancer, there is a certain uniform treatment for that cancer. So no one is denied access. The challenges that I've seen when I travel to Canada and also just recently to Norway or to Sweden last year was the challenges is integrating new innovative therapies. So a lot of the places like Canada and Sweden, when they do have new innovations come out, they are not immediately implemented. They have to undergo a rigorous review to ensure that they're both efficacious and not cost prohibitive. So in a way, the access is there, but there is at times a barrier for the implementation of new innovations. In the US, it's in a way flipped a little bit.
People big time.
If you're below 65, you may or may not have access to, if you have insurance, you will have some access, but we have to be aware that just quote unquote, because you have insurance, that doesn't mean that an individual patient doesn't pay for the costs associated with treatment. Usually insurance pays for part of it. Having said that, in the US and at some places in Europe, it is easier to have access to new treatment innovations. So it is a bit of a double-edged, it is
Yeah.
a double-edged sword. The challenge is that it does lead to a two-tier system where those that don't have the resources will get some level of care. What breaks my heart is that when people that don't have insurance, or maybe, they have just recently moved to the United States, have no insurance, then, whatever we want to say as physicians, costs are drivers of the quality of care that's delivered. But if you have all the resources, you have access to everything.
Yeah.
So there are lots of pluses and minuses when you
No.
compare different healthcare systems.
Whatever the pluses or minuses, Dr. Mukherjee, so I have to, health is a human right. There is no compromise on that one. It is earth belongs to the humans. Health is a human right. It is not a policy. It's not a politics. I don't know. I cannot convince myself that somehow it is a political cancer. Is a political. It's just very hard to swallow that. Innovations. You're saying this is a nonsense that Silicon Valley gives to you. $500 billion data center will find a cancer cure. It is the biggest bogus game that you play, and people buy it, and then it is a problematic, and a lot of people need to raise a voice. In fact, this intelligence is nothing to do with the data centers. That they came up with a new scam, in my view. It is a scam directly affecting people instead of spending time on the caretakers. The most important, whether it cured cancer or not, Dr. Mukherjee, the most important is caring people, those people who are affected, dignified death, giving a care. That is more important than even a death itself. Treating, I have a $500 billion data center is going to cure overnight. It's a nonsense. I live in Silicon Valley. I criticize them all the time. So I have no problem at all. I'm going to be standalone. It is tough, but they don't treat me. They get mad at me, but that's okay with me. But I am going to fight for the right of that dignity all my life until my last breath. But let us go into the next level. Let us stop going to the philosophical aspect. The next one is purchasers, he said. Let us talk about purchasers a little bit. Each one, you give us 7 of them. Just let us run through those 7 of them. So purchasers. Who is the purchasers here? Insurance companies or the patients? Who are? You said that they're important purchasers.
Yeah, no, I think it's an important area that oftentimes gets overlooked. I've been working with healthcare purchasers for about 20 years or so, and what defines a healthcare purchasers is that so number one,
Who are the healthcare purchasers?
Yeah. So I think, before I start, I want to make sure that I'm crystal clear that the center of the healthcare ecosystem is the patient. Full stop. There's absolutely that the patient needs to be the center of that system. Now, having said that, when I talked about the 7 Ps, the patients, the providers, the payers, the purchasers, the policy, the politics, and pharma, every one of those feels that they are the center of their own system. So it's this weird solar system where we all orbit around the sun, which is a patient, but all these other Ps think everything's revolving around them. The way the purchasers fit into this is that their view is that they are the ones that are buying goods and services. So when we look at the services that we provide as physicians, we're in the service industry. And it's just like any other product that you sell, or, I'll probably get in trouble for saying this, it's almost like plumbing or any service that you provide. You have a certain domain expertise, and in order for your business and your services to continue to succeed, number one, they have to show value, which physicians obviously do, and all healthcare providers do. But on the other hand, someone has to purchase your services. So if we were giving our services and nobody was purchasing them, then we would feel morally satisfied, but financially, we wouldn't get paid. So from a purchaser standpoint, my point is that a healthcare purchases is who purchases our services. Now, what defines a healthcare purchaser? Okay, so that's the next step.
That is, I have an answer for that, actually, to be honest with you.
Yeah.
Entrepreneurship is the best way to solve that problem. People like me, that is where the free enterprise should be freely available to all people. If I want to buy an ultrasound service or X-ray, MRI service, they should able to look at it where I can, including the government. People who cannot afford, government can go look at, hey, where I can buy the cheapest one. So that is where the free enterprise system can get in and really purchase all these things. So there is a place for free enterprising. There's a big misnomer that the moment you say the healthcare for all means socialism, that is not true. It is that you can do the entrepreneurship, you can do innovation, you can do competition, free market system. And that is a big thing to American public to understand that difference. Let me comment on that.
Yeah, no, I think where I'm going with this is that who are the people that purchase our services? Well, number one, they're the healthcare insurance companies, the private insurances. Number two, they are the government. The largest quote unquote purchaser of healthcare services is Centers of Medicare and Medicare Services, because they're the ones that purchase our services. And therefore, when we talk about reimbursements equate to the amount of revenues that we make as both physicians and also hospitals and so on and so forth. But then you have this other entity, and those are small to mid-sized businesses. So you kind of mentioned entrepreneurship, right, Ramana?
Yeah.
So for instance, let's say if you wanted to start a 20 or 40 person company, one of the biggest barriers that you're going to have to face is that when you hire 20 to 40 people and you want to get the best and the brightest, one of the questions that comes up is how they're going to want health insurance. So you, as a small business owner, are going to have to ensure that you are purchasing the ability for your employers to have access to healthcare.
Yeah.
And so when we talk about large companies like Google or Apple, when we talk about United Healthcare or Blue Cross Blue Shield or the government, CMS, those are the big healthcare purchasers. But on the other hand, if you look at the small businesses around the country, one of the biggest costs that they have to face is purchasing healthcare. So when you talk about new innovations in healthcare, let's just say some of the gene therapies, like treatment for sickle cell disease, there have been new gene therapies that are put out for treating for patients with new hearing loss. Every day we hear about new targeted molecular therapies for different types of cancers. That leading edge of innovation is very expensive. And so part of the barriers that people run into is if you are a small to mid-sized company and all of a sudden one of your employees has a malady, but there's a new treatment that comes out that costs several $100,000 to treat, you get into some really challenging areas regarding leading innovation that may not be available to any countries, but they're available in the US. So then you have this moral hazard about what do you do in these situations? So that's the challenge that we have.
Hold on, sir. You came from a heritage, West Bengal. There's the epicenter of mathematics. I do not believe 1 second mathematically you cannot solve this problem. Is a risk analysis. The spending money is basically risk analysis. How you spread the risk analysis. There is a mathematical solution for this. I can come back. You came from a background that's where the mathematics was the center. I think mathematics can solve this problem of this. Dumping all the cost on one person is a risk analysis. This is a game they play very well. But the biggest question we should ask whether we need insurance companies or not. First of all, if their function is a risk analysis, I can do better. So I would say a big supercomputer can solve all this problem. So cost and analysis and everything you can do with the quantum computers and all those things. So we can. This is a political game a little bit more than mathematically. I wanted to say that to you because you're from the West Bengal. I learned mathematics from Sachindranath Bose and all those people. Is a mathematically solvable. this problem is not beyond access to care. Affordable care is mathematically possible. It is whether you can do politically or not, that's a different issue. But mathematically, absolutely possible. That's
Yeah,
what.
I mean, that's the basis of insurance, right? It's all based
Yeah.
on actuarial tables, risk assessment, risk analysis, and basically determine how much money can you bring in, but based on how much money that comes out.
Let us talk
I'm
about it.
Yeah, I'm kind of like you. I think I actually did a fellowship with the Leapfrog Group, which is the company. It's actually a separate entity, nonprofit that grades all the hospitals in the country based on quality of care. And I remember I was talking to the CEO when I did my fellowship about 4 years ago with the Leapfrog Group, and she's always rated as one of the top most 100 influential women in the United States. And so I asked her, do you believe in Medicare for all? And her comment was very interesting. She said, well, I believe for Medicare for most. And so I think her comment was, I think everyone should have the access to it if they want to have access to it. But from her perspective, it should be an opt-in if you're under 65 years of age, as opposed to a mandate. So that's just a different opinion when it comes to that.
Whatever the name you call Medicare, Medicaid, all doesn't matter. You can differentiate people through these classifications. Human health is not classified that way. It is just a very, very wrong, morally wrong. But anyway, I want to go to cover all our piece. We have a little bit time, and I want you to get 7 piece. Now let us talk about providers. You know, this is a new game. The Silicon Valley philosophy is we want to replace all the doctors. The radiology is easy. The first one, we're going to replace radiologists overnight. That is, they talk all the time here. I get tired of it, but these people are. I don't know whether the pseudo intellectual game is how far is true, how far is not true. We don't know. Is that really intellectual game they're talking, or they're talking a lot of nonsense? Which one? You are the really preeminent author or preeminent author on this one. Tell me, what is that AI can replace all radiologists overnight? Tell me, is it possible or not?
Well, I think your question is very timely. I'm actually going to be delivering a lecture in Budapest in a couple of months about at least, I guess it's an update on the future of radiology. So let me preface it this way, Ramana. Did my residency in radiology from 88 to 92. So I was interviewed on a different podcast not so long ago, and the person that was running it said, in your 4 decades of radiology, and I paused for a second, and I said, 4 decades? That sounds like a long time. And then I realized if I started in the 80s and now we're in 2020, that's actually 4 decades of radiology, which is a little bit frightening to me. But where I'm going with this is that since the 4 decades I've been in radiology, they've predicted the death of radiology 7 times. And the only thing that's happened is that our field just continues to grow and expand. So when it comes to artificial intelligence, that was number 7 on the death prediction of our field. And so what accelerated this was a comment that was made in 2016 by Dr. Jeffrey Hinton, who won the Nobel Prize for Physics in 2024. And you being a physicist, you're probably familiar with that name. So he predicted in 2016 that we should stop training radiologists. The YouTube video is out there. It's been viewed hundreds of millions of times. And certainly every AI lecture that I go to, including mine, always have the clip of him saying this. Well, what was interesting was in June of 2026, so this was only 2 months ago, he was on another podcast and he actually said he made the wrong decision. It was a bad decision. Yeah. So now all of a sudden he laid claim to and made a comment about the future of our field based on his interaction with a single radiologist. Now, over time, I think logical people, a lot of people caught on to this. So a lot of people that were quote unquote leaders in radiology heard what Hinton said in 2016, and then they would jump and they would go to their national meetings, and I don't know if they were trying to be visionary or provocative or just whatever, but they sort of glommed onto this and started throwing fear into the radiologists. I think down deep, I think those are smart people. I don't think they're as naive or as silly as they came off. But what the unexpected consequence was not necessarily being provocative, but that affecting the interest of medical students wanting to enter radiology. So
Yeah.
we lost about 5 or 7 years of interest from medical students, the
Oh,
best and
beautiful
brightest
point you
ones
made.
to go in.
Thank
And
you for
even
making
now,
that
I don't
point,
think
sir.
we're,
No,
I
no,
don't think
no, I want to
we haven't fully
re-emphasize your
recovered.
point. I want to re-emphasize your point, Dr. Mukherjee. So their fear, their baseless fear caused people not to enter radiology field. It is really travesty of justice. It is really it's a really tragedy in my view.
Yeah, and so now, even now, when every year in radiology, we decide who's going into it based on the match. So right now, my son, who just matched in medicine and pediatrics at UC San Diego, which is near where you are. So I had the data for the match for radiology, and it turns out like every American graduate that wanted to go into radiology had a slot, and everything else was filled up by international graduates. So my point is that if you looked at this 10 years ago, the number of U.S. graduates that were entering radiology exceeded the number of positions. So despite the fact that if you look at the total of radiology positions were filled, a higher percentage now are being filled by foreign graduates because the interest in U.S. graduates is not there. And to me, I was talking, with my wife about this. I think she's right. I think it is still this persistent fear of less jobs in the future. And even recently, I saw another article saying, well, it's going to reduce radiology work by 30%. I think that's silly. What I can tell you right now is that I've been doing this for a while. I consult with an AI company that is associated with about 170 individual AI companies. And I posted this on LinkedIn. So if you want to know my opinion on this, and you can use this in the future, Romana, is that when we look at the ability of artificial intelligence to detect lung nodules, to detect abnormalities, AI will help radiologists detect abnormalities, but radiologists make diagnosis. And it's that ability to make diagnosis which is our true utility. Now, you can come back to me and say, well, if you Google your symptoms in Gemini, it can give you potentially what your diagnosis is. Well, this is what they said about 10 years ago when software companies like WebMD came out, and a lot of other software companies from Silicon Valley came out, said that you put in your symptoms, you will have a software that'll tell you your diagnosis. That did not affect at all the demand of individual patients for their doctors. It allowed the patients more consumerism. It allowed them more ownership. I think there was a great idea because it allowed them to be more knowledgeable about their disease. And if patients have more knowledge, they're going to be in a position with more shared decision making, which makes them feel more comfortable and eventually improves the overall value of healthcare. But that didn't replace physicians. It was more helped consumerism as opposed to eliminating the need for physicians.
The problem is here in Silicon Valley.
Yeah, so moving forward, it's us. AI will help us detect more abnormalities, but physicians will always make the diagnosis and radiologists will make the diagnosis, and that's our true value. And I'm firmly believing this for the next 4 decades.
I want to tell you, I'm developing a program, developing a platform. In the platform, my first principle is that when you escalate to the human beings, that's it. AI cannot override, period. That's what the first principle that I wrote is that AI cannot override human judgment. That's period. Then you do anything else. Then that is a key. The AI agrees with it, actually. AI says that you're right. This is the demigods we create in Silicon Valley, Dr. Mukherjee. is, the Kostla saying, "Doc, we are going to replace doctors," and then Elon Musk is a singularity we're going to reach. All this nonsense is a lot of nonsense. They talk about it. It is really they don't understand the intelligence. I'm not saying that they're overconfident, and when the Sundar Pichai came on the stage one day, and then he was pitching on how we can predict the seasonal flu in 3 months in advance. You could not predict this storm. This is a COVID-19. 8 million people dead. So where all these journalists ask questions? They never ask any tough questions. I think journalism itself is a failure in that sense. They need to ask it. They need to have some background in mathematics and physics and medicine. Otherwise, they're not asking tough questions. Okay, anyway, that is Silicon Valley's worldview. But let us talk about the another P for you. What is other P? Next P. Let's go to the. I want to cover all P's.
well, the only thing I wanted to add on to what you're saying, Ramon, is that I agree with you. It's just that when we look at the outcomes of what we do as physicians and healthcare providers, is that we want to improve the outcome of patients. We see the patients. We have to look them in the eye. We see the fear. We want to offer them the treatment, and we want to do everything we can to the information that we provide is going to provide them the best outcome.
Yeah.
So when we look at our quote unquote success, our success is to saving that patient and allowing them to eradicate the cancer so they can live a normal life. If you flip it to Silicon Valley, from their standpoint, with new startups, the ability to maybe improve healthcare is not the end goal. Their end goal is to improve shareholder value. Me having an MBA and understanding startups. In fact, I've invested a couple of startups, sold a couple of companies.
That is the only
I
goal they
actually
have.
understand the difference, right? So I think when it comes to people talking about hype, we're all familiar with the Gartner curve. In order to, as the Gartner curve goes up, you have to have hype. That hype increases the likelihood that you're going to have VC funding. When you have the VC funding, you can maximize your potential strike price. And if you have enough growth and your ultimate goal is to sell the company or maybe to go public, that's the end goal. So patient outcome is not the ultimate goal. The ability to try to improve patient outcome and document it allows you to reach your goal, which is to improve the value of your company.
That is where the government play a role, right? That is where they need to put the policies in place, that where the funding should go and where the funding should be allocated. They can limit these people's, dreams and pseudo lucid dreams. Let's talk about other P. What is other P you're talking about? We covered four of them so far, 4 or 5.
Well, which one would you like? We had the patients, we had the providers, policy, the politics.
You want to talk about policies a little bit? You can talk about policies anyway. I don't want to get into too much politics, but I don't want to go to. I don't want to end up in somewhere. Politics is dividing here in this country so much. Instead of looking at the human as a health point of view, health is a human right, and doctors need to raise a voice. They don't need to play the tune for the insurance companies and pharmaceutical companies. Fiddle. They're doing that. I feel that. Sorry to say that to you. You're a doctor, but I feel that that part they failed in that sense, that playing the fiddle to the when French Revolution came is when he was everybody suffering and is playing violin. So that's what we feel. Doctors are then they comply and they lose the control. Tell me about a policy point of view. I don't want to go into policy and politics too much, but just in general. I don't want to get you into trouble also.
No. What do you mean? What specific policy are you referring to?
So cancer moonshot is another policy they started it, right? And I'm a part of the. I want to mention to you. I thank you for your help also. I don't want to say that I got into quantum with San Diego State and Quantum X. That's yeah, I'm involved in the mentorship of that one, so I'm going to do that. Really is a blessing. I love physics, and any way we can solve the problem is better for us. And I'm inspired by the physicists, the mathematicians from your state and my state, and they are always guiding for me in my vision. So let me ask you a question on the in the cancer side of the in the last one you're saying about the death itself. Cancer and how cancer, some people think is a death sentence, as you said. How do you, it's a philosophy question I'm asking you as a particularly Rabindranath, you're Shantiniketan, director of Shantiniketan. I wanted to mention to the audience, Shantiniketan is started by a Nobel laureate poet Rabindranath Tagore. He wrote a lot of poems in Bengal, translated into English and other languages. And then Indian national anthem was written by Rabindranath Tagore. So he is a Dr. Suresh Mukherji is the director and one of the advisor for that group for the university. So as a policy maker, as a humanity, as an advocate for humanity, death is something that we cannot avoid. Silicon Valley talks about longevity every day. They think they can avoid death. All these billions of dollars they wanted to extend the death, and some of them are scams, some of them are real, some of them are not true. We don't know what it is. So when cancer hits people, that the reality hits them. So how do you person deals with the death part of it? It's a tough question. I want to ask you a philosophical aspect of that, your background a little bit.
Yeah, I don't, I think that's a tough one. I think it's always difficult to answer a question when you don't know what the answer is. So in the sense that how do you counsel someone that is near death when you don't know what's on the other side?
Yeah.
So I think the closest that I've come to it is having two parents that have died. And the only thing that I can say, um, and this is more personal as opposed to the real world, is both my parents, I think, at least my father, I knew was going to pass away. He had pancreatic cancer, and then my mother kind of had the dwindles. And I think one thing that I learned during my experience is, every generation thinks they're smarter than the prior generations. I think my kids clearly think they're smarter than me. Probably true. Um, for the longest time, I thought I was smarter than my parents, and I was dead wrong. Um,
At the end, that's,
and so I
that's the
think
best
part of it,
wisdom you give. Yeah.
yeah, I think part of it is when you are seeing individuals that are near death or have cancer, then have to make these difficult decisions that are made probably by the patient and the family. Um, the initial reaction for uh, family members, and I equate family members with also physicians when they are counseling patients that have terminal illnesses, is to try to tell them what they do. And they try to do it well meaningly to give them suggestions and advice. So you ask me, what advice do I give people? I think the main thing that I learned from watching my parents go through this is the first thing that I had to do was, we talk about the circle of life. Yeah, this was not a surprise to them. They were in their 70s or 80s. They may not be as smart and up to date on the current iPhones, but they have a lot of wisdom, and they've had time to think about their mortality. And just like you or myself have already started thinking about, what would happen the next phase of life, they're at the next phase. So I think the first thing that I do is ask them what they want, kind of explain to them the situations, and ask them what would they like. And surprisingly enough, when you ask and then you listen, you realize that they are much wiser, much more introspective, and much more knowledgeable about their fate than you had ever imagined. So from my standpoint, in these situations, the first thing that I always like to do is, once I try to explain the situation, people aren't dumb. I think a lot of, with all due respect, politicians and media and so on and so forth, I think they kind of underestimate how much we as average people know and how much we've thought about various situations. So if you give the chance to ask them people questions and then listen to their responses, sometimes the decision's already made for you because they've already decided what they want. So for me, that was very helpful as I kind of worked with my parents through that time. And that's the advice that I would give for anyone that are taking care of patients that now have to face with the reality of a situation a cancer that may not be curable.
Beautiful. Dr. Mukherjee, whenever I speak with you, you shed so much light on it. You're my not only a friend, mentor, and you give a different perspective. I always admire your perspective. Your Medbix webcast is an open platform for you. You can come anytime. We can vacate that guest. It doesn't matter however it is, President of the United, anybody. I will vacate for you. Thank you so much. It is a truly an honor and a privilege. It's because you shed so much light personally affecting me, and think about my father and mother and me and my children. It is you. We this is the one thing that connects all of us humanity together. You did that beautifully well, and you crossed that complex cancer thing. The way you navigated is beautiful. I mean, I can, with the 7 P's that you did that, where the interest should be falling inside. You should write a policy book, Dr. Mukherjee. One book I would suggest you, that right from the point of the patient point of view, what should be the policies for as you said, that one of the strategies, the national strategy must be there. When the moment they declare cancer, there must be a strategy, some steps must be. But common to all. Treatments may be different, drugs may be different, all. But I think people like you should write that book, and you have such a knowledge in that area. And thank you for coming on the show. You're truly you're my favorite guest. Always I tell everybody, Dr. Mukherjee is my favorite guest. No question about it. Thank you, sir. It's a privilege and an honor to have you.
All right. Thank you very much, Ramana. Keep up the great work. And again, it's a privilege and an honor for me to be invited by you to participate again in this. Keep doing what you're doing, because it's pretty special.
Thank you, sir. Yeah, it's coming from you. Thank you. Good night, all of you.
Thank you.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.